I'm Peter Block here in Orlando, Florida at the ACC annual meeting for On the Scene. Sitting next to me is Ambarish Pandey, who is from UT, Texas, and Ambarish is a fourth-year fellow. It's nice to have an FIT here for a change rather than just a whole bunch of people that are senior. So Ambarish, you've been talking and working on heart failure and now are interested in the sort of metrics that we look at in terms of outcomes in heart failure. So tell me about the study that you presented in a short version. It's a tricky study, and then what kind of information the folks out there will get from your study and take-home message.
Thank you, Peter, for the introduction. Yeah, so basically in this study, we have looked at the association between 30-day risk standardized mortality rate at for heart failure in hospitals that are participating in the Get With the Guidelines heart failure program to see how this metric can predict long-term outcomes in the patients hospitalized at these centers. The current paradigm in our health policies is to rank hospitals or based on their 30-day readmission rates.
Right.
And we have previously shown that the performance based on 30-day readmission rates don't necessarily track with long-term clinical outcomes or in-hospital care quality. So considering this knowledge gap, we wanted to see is there a better metric for this, and 30-day risk standardized mortality rate was the metric of choice for us to evaluate to see how that tracks with long-term outcomes, specifically mortality in heart failure patients.
I see. So you looked at a whole bunch of hospitals to see what their 30-day mortality was and trying to figure out if that metric was a better metric.
Exactly. So we looked at the hospitals that were participating in Get With the Guidelines heart failure program between 2005 to 2013, and there were over 300 of these hospitals that we included with over 100,000 participants, and we calculated the 30-day risk standardized mortality rates and ranked the hospitals based on the 30-day risk standardized mortality rates into high-performing or low-performing, such that hospitals with high 30-day risk standardized mortality rates were low-performing and hospitals with low 30-day mortality rates were high-performing. And we looked at the association between the performance based on the mortality rates at 30-day with long-term survival in patients with heart failure.
Okay, so we're getting to the bottom line here. So was in fact 30-day mortality related to long-term mortality in heart failure?
Exactly. We saw that there was a strong graded inverse association between hospital performance based on risk standardized 30-day mortality and long-term survival, or such that hospitals that were high-performing had up to 25% lower risk of 5-year mortalities compared to hospitals that were low-performing. And we also saw a difference of more than 100 days in the median survival between high-performing and low-performing centers.
Got it. So if I were CMS or a government agency, how do I use this information, I'm sure they will, in terms of trying to make hospitals do better?
Yeah, that's a great point. And our implications for health policies are quite significant from this study. Basically, the current health policy paradigm is all hinged around 30-day readmission reduction and hospital performance judging by 30-day readmission rates. And since we have shown previously that 30-day readmission rates are not really as robust predictors of long-term outcomes, we think that there needs to be a shift in the balance towards 30-day risk standardized mortality rate. And in the current penalty system that we have with the hospital readmission reduction program, the penalty that a hospital pays for higher than expected readmission is 15-fold higher than what they pay for higher than expected mortality. And I think based on our findings, we need to tilt that balance back in favor of 30-day mortality, which is a more robust predictor of long-term survival.
Okay, so one last question, and that is, so you're looking at 30-day mortality, and the hospitals are either good or bad at that. So what do you think the difference is? Are the doctors better? Are the medicines better inside the hospital? Or is something that happens between discharge and 30 days that makes the difference?
That's a great question, and that's something that we are trying to study further to better understand what makes a difference in the long-term survival in patients that go to a high-performing versus low-performing centers based on the 30-day mortality. We did see in our study that hospitals that were high-performing had higher availabilities of PCI, cardiac surgeries, and heart transplant options. And also we saw that hospitals that were high-performing had more post-discharge follow-up among patients after their index hospitalization, had greater utilization of ICDs and CRTs during the index hospitalization. So there was some differences in the care quality that was provided during the index hospitalization that may explain some of the observed differences in long-term survival. But to better understand it more comprehensively, I think we need to do further studies and look at what happens after discharge that may be making a difference as well.
I would guess that would, the follow-up and the nurses that call and all that kind of stuff.
Exactly, yeah.
Okay, well, thank you very much for all the guys out there working in heart failure. These are important metrics that suddenly now give us a good handle on whether or not your hospital is performing well or not. Take a look and see how you're doing. Thank you very much,
Thanks
Amber.
a lot for having me over.